Welcome to Chiropractic Science, where you get to hear interviews with leading chiropractic researchers from around the world. Hear about chiropractic research from the authors in plain English, not through the media, nor a middleman. My name is Dr. Dean Smith, and I am the host of Chiropractic Science. I am an associate clinical professor in the Department of Kinesiology and Health at Miami University, and I'm also a chiropractor in Eaton, Ohio. My research interests relate to understanding how chiropractic affects motor control and human performance. Today, I have the privilege of interviewing Doctors Cindy Peterson and Kim Humphreys. But before we get to the interview, I wanted to thank all of you who have subscribed to Chiropractic Science, and I'm especially appreciative to all of you who have contributed 5-star reviews on iTunes. iTunes reviews really help others find out about chiropractic science. So, if you like the show, please take a second and write a review. It will support chiropractors everywhere. Here's a review from Lil Cairo from the UK who says, "Great for keeping your knowledge up to date. I think this is a fantastic series and is really well presented. It's a perfect length if you are driving, and it's a great way to keep up to date with all the latest research. It's great to hear direct from the people out there doing all the hard work. Highly recommended." Well, thanks, Lil Cairo, for your review, and I look forward to sharing your iTunes review in a future podcast. Please consider making a contribution to Chiropractic Science to keep these podcasts going. You can do so on our website either by making a donation or by purchasing the evidence-based patient education slides presentation at chiropracticscience.com. All right, on to the podcast. Well, let's get on with the interview with Drs. Cindy Peterson and Kim Humphreys. Cynthia Peterson, RN, DC, DAC Masters in Medical Education, has worked as a chiropractic radiologist, researcher, and educator in 4 countries. She retired from her positions as professor and researcher, Radiology Department, Orthopedic University Hospital, Balcrest, and professor, Chiropractic Medicine Program, University of Zurich in 2017. She has published numerous research studies in many journals, including Spine, European Spine Journal, American Journal of Röntgenology, JMPT, Skeletal Radiology. She is currently a visiting professor for the Chiropractic Department in the Faculty of Health at the University of Johannesburg, South Africa, and is a quality assurance consultant for the European Council on Chiropractic Education. Barry Kim Humphreys, BS, DC, PhD, is Professor Emeritus, Faculty of Medicine, University of Zurich. He retired in July 2017 after 9 years as the first professor for chiropractic medicine in Switzerland. During this time, Professor Humphreys was responsible for the development and accreditations of the chiropractic education program, research portfolio, and teaching clinic within the university, medical faculty, and teaching hospital. Professor Humphreys is a graduate of the University of British Columbia, Canadian Memorial Chiropractic College, and the University of Southampton. He has been academic dean, Anglo-European College of Chiropractic, dean of graduate education and research, CMCC, and professor of chiropractic medicine, University of Zurich. He has been active in research including chiropractic clinical outcome studies for back and neck pain, functional MRI studies of chronic pain patients, and back pain in various gravitational environments. Drs. Peterson and Humphreys, thanks so much for coming on the Chiropractic Science podcast.
It's my pleasure.
Thank you very much for having us.
Yeah, absolutely. I've wanted to have you both on the podcast for some period of time, so I'm really excited to have you both on. Can you tell us how you became interested in becoming chiropractors?
Well, I'll go first. My father suffered from quite severe recurring episodes of chronic low back pain every year. Had about 1 to 3 episodes. And he eventually went to a chiropractor who helped him immensely and enabled him to go back to work quickly with only a few treatments. And in only a few days, he was back at work. I had a few amazing experiences myself with chiropractic treatment for acute neck pain and lower thoracic pain. And when I was a student at UBC, I had a chiropractor, Dr. Doug Alderson, and he suggested that I should become a chiropractor. So I went and observed him treating patients on Saturday morning, and it was really a great experience. I really enjoyed it. So after UBC, I applied and started studying chiropractic at CMCC in Toronto.
Well, I'm next. Originally, I trained as a registered nurse and worked primarily in an intensive care unit in a large hospital in Portland, Oregon. And I have to admit that was excellent clinical experience. But after a few years, I realized that many of the patients in the ICU were there because of their not so good lifestyle choices. And I wanted to do something where I might be able to prevent some of these patients ending up in intensive care. I had also been a chiropractic patient for migraine headaches, and that had helped me tremendously. And so because there was a chiropractic college in Portland, Oregon, Western States, now University of Western States, it was easy to attend. And I worked 50% as a registered nurse while I was a full-time chiropractic student. The ICU experience really helped me a lot because I saw every single pathology in the ICU that we were studying in the textbooks in chiropractic college. And I was very comfortable with things like pathological reflexes and neurological cases. I did not want to be a medical doctor because I saw the horrendous work schedules they had, and I didn't think those were very healthy. So chiropractic was my choice. I graduated in 1984, and then I did not go into a treating practice because I fell in love with radiology as a student, and I went directly into the postgraduate radiology residency program and finished that and obtained my DAC bar qualification in 1988.
That's great. So did either of you spend much time in chiropractic practice before you got involved in research?
Yes, I did. After graduation, I practiced 5.5 years in British Columbia. I had my own practice. And then I went to England. I moved to join the Anglo-European College of Chiropractic in England to teach at that college. But I still practiced a few hours in the morning at AACC in what they called faculty practice. And then when I became a professor at the University of Zurich, my contract actually stated I must practice 2 half-days per week in the hospital. And I really enjoyed doing this. I did it for 9.5 years in a multidisciplinary environment. And I was, it was wonderful because I was considered a valued team member, and I had access to every clinical test and examination and referrals, everything I wanted to really practice, I think, in a full way as a chiropractor. So that was just an amazing, kind of the crowning for my whole chiropractic career.
That's amazing, especially that they required you to practice. I love that. What a fantastic opportunity. Dr. Peterson, how about yourself?
Yeah.
Yes, well, I had part-time radiology consulting practices in Oregon and England and actually throughout Europe and also in Switzerland. But I never was a treating chiropractor because when I graduated from Western States Chiropractic College, at that time there were chiropractors on almost every corner in Portland, Oregon, and I could make a lot more money as a registered nurse. And so that was another factor toward going into the radiology residency, besides the fact that I really loved radiology.
Gotcha. So what was it that got you both interested in research?
During my studies at UBC and CMCC, I was really always interested in research. I really wanted to learn how to do research and to be involved in the research environment. So after practicing in BC, that's when I decided I wanted to do more, get involved more in teaching and research and carve out an academic career. So that's what motivated me to get started, and I started as a faculty member at the AACC in England.
For me, when I was a radiology resident, part of that had a research requirement. And so I started doing some smaller studies at Western States Chiropractic College, and I even was privileged enough to do one with Dr. David Cassidy back in the 1980s on lateral bending. And I learned quite a lot from those experiences and really enjoyed it. And then when I moved to England to be head of the radiology department at the Anglo-European College of Chiropractic, I found out that every faculty member was required to supervise the student research projects, and every student was required to do a full research project before graduation at that time. So that was new to me, and we would have 5 to 6 students per year that we'd be supervising. And Professor Jennifer Bolton was in charge of these student projects at the time, and I really learned a great deal about research from her. She was an excellent mentor, and we subsequently have published several papers together. After that, when I was working at CMCC, I did a few publications, but I found it very challenging to do research in North America in isolated chiropractic colleges because the connections and the resources were just not there. And so it was very frustrating. So moving to Switzerland was an amazing opportunity. And going there, I knew that research publication was critical and essential. It was do or die. You don't stay in a medical faculty if you're not publishing. So it was thrilling, but it was intimidating. But we had more resources than we could possibly imagine, everything at our fingertips. And the collaborations within the hospital were easily available, and they welcomed us with open arms. So that was sort of a fantasy, chiropractic research fantasy land there for those 9 years.
Cool. Well, I definitely want to get into your experience in Zurich. You've both published a tremendous amount of articles in top journals such as Spine, PLOS ONE, BMC Musculoskeletal Disorders, JMPT, and many others. And today we'll discuss a few of these, but before we get into these articles, I do want to get more about your experience in Zurich because it sounds like such an amazing place to be, and you've both contributed so much from there. Can you tell us what Zurich was like compared to maybe the rest of the world? We've heard a little bit about your experience, but I'm certainly curious, and I know other chiropractors around the world are going to be very curious to hear about your experience in Zurich.
Well, I can start by telling you how we actually got the appointments in Zurich in the first place, and because we need to give credit where credit is due, and it actually all started back in the 1980s at Western States Chiropractic College, where Dr. Daniel Muehlemann was a student of mine. He was in the first cohort of Swiss students to attend that college, and we became friends over time. And the friendship lasted years, with his family visiting us in England, and we visited them in Switzerland. And he was aware, when we had moved from England back to North America, he was aware that we were not integrating very well. We didn't try, I have to admit. We would admit we didn't try to reintegrate into the culture, and we weren't very happy. And as I said before, it was also very hard to do research there and frustrating due to the lack of resources. I also couldn't get my radiology residents even into hospital radiology departments like I could in Europe. So one day, without another job, I resigned from my position. And a week later, Kim also resigned, and I decided to just send an email to Daniel Muehlemann, just sharing the fact that we had resigned. And I don't think it was 24 hours later, he phoned and asked if we would come to Switzerland and for Kim to take up the position as head of the new chiropractic medicine program. They'd been looking for 2 years for somebody to head up this new program and found nobody willing to do it. There are very few that could because they wanted a German-speaking person, of course. And after 2 years, they finally gave up and said, well, we'll have to go with English-speaking. So that's how they contacted us, and that's how we ended up in Switzerland. So I think Kim will tell you more about Zurich and the program.
Yes, the law for the Swiss medical law in 2007, there was a revision to it. But I must say that what happened in Switzerland and how chiropractic became part of the medical faculty of the university began many, many, many years earlier. And the pioneers of the Swiss Chiropractic Association worked long and hard, as well as a patient organization, to try and get chiropractic not only within the insurance, paid for by insurances, but also into a university and preferably a medical faculty. So it started a long time ago. And that led eventually to this Swiss medical law revision, where chiropractic became one of the 5 medical professions. So along with human medicine, dental medicine, veterinary medicine, and pharmacological medicine, there was included chiropractic medicine. And this new law required a chiropractic program within a medical faculty in a Swiss university, and it also required a professorship to lead the program. So the first cohort started in September 2008. And so that's when it all began for us.
Terrific. So how did the program develop over time, and what specifically were your connections like? What's the scope of practice in Switzerland? I'm just curious about some of these other aspects of chiropractic in Switzerland.
Okay, so we were integrated into the regular medical faculty and medical curriculum. By the way, they do not use the term medical school. They use the term medical faculty as the medical school. So our students were considered medical students with the pathway towards being chiropractic medical graduates. Our students therefore had to pass the entrance exam at least the same level as their human medicine, the other human medicine applicants. And typically 1 in 5 applicants were successful and accepted. We only had 20 available places out of the 250 medical program placements. And therefore, our students were really the cream of the crop. And not only academically, but they were wonderful, well-rounded individuals. We really enjoyed being with our students and teaching the students. And our students were required to do more than the human medicine students. And that's because they had to take all of the medical courses in the 4 years, plus chiropractic courses along with it. And this included observations in hospital, ambulatory medical, and chiropractic clinics. And our home was within the university hospital at Balgras. Perfect home for us. It was a musculoskeletal teaching hospital and a university teaching hospital. So this really was the appropriate place to be. This is where the patients were, and this is where the experts were in the facilities. I'll say a couple of things about the curriculum. It was a 2-cycle curriculum. So first they do 3 years, a Bachelor of Medicine with a focus on chiropractic. After that, they do a 3-year Master of Chiropractic Medicine, and this contains some medical courses still in year 4. They have to do a master's research thesis, and several of these have been published in various chiropractic and radiology journals. Year 6 is the internship. The students are called under assistants, similar to the medical model. So they're not called interns. And the cohort of students in the 6th year, they were divided into 2 groups. So one group would do 5 months rotations in orthopedics, rheumatology, neurology, radiology, and internal medicine. And the other part of the cohort would do 6 months in the chiropractic teaching clinic, which was also right in the hospital within the orthopedic part. So in 6 months, under supervised clinical practice, they have to have seen a minimum of 80 new patients. They had to have a minimum of 800 patient treatment visits. And most of these patients, about 50% of the patients were hospital referrals, mainly from orthopedic. And they were very difficult patients. These were the ones being referred because medicine didn't know what to do, and they wanted to see what chiropractic could do. So they referred to us.
Wow, that's totally amazing, and I really appreciate you going through that in some detail, and it gives me insight as to how some of these studies that you've done there actually took place. So I'd like to get into those studies.
Can I just add one thing, sorry, before you do?
Yeah, please.
What Kim said was absolutely excellent, but what is also important to know is that in Switzerland, every chiropractor is required to do a postgraduate program, a residency program, and it's 2.5 years full-time, including hospital rotations. And it is fully accredited by the Swiss accrediting agency, the same agency that accredits all of the residency programs in medicine. So they get paid during the residency, but they have to work under supervision and take another exam, the postgraduate exam, before they can be independent chiropractors. So it's really, in total, about an 8.5-year program before they can go out and have their own practice.
Wow, that's pretty intense.
It is, but they like it. And the postgraduate program has been in existence for decades. It was only accredited, I think, because I was in charge of the postgraduate program when we first arrived in Zurich. And it was accredited, I believe, in 2010. Prior to that, it wasn't, but they still had to do the program for several decades. And in that program, they had medical doctors teaching on the program. So again, that broke down barriers over the years.
Very good. Let's get into some of the papers that you've and the first one is called Symptomatic Magnetic Resonance Imaging Confirmed Lumbar Disc Herniation Patients, a Comparative Effectiveness Prospective Observational Study of 2 age and sex-matched cohorts treated with either high-velocity, low-amplitude spinal manipulation therapy or image-guided lumbar nerve root injections. And I think I have the idea of how this developed based upon what Dr. Humphreys said with the collaboration between orthopedics and chiropractic. But can you tell us how this research got started and what you found?
I wanted to quickly introduce really the background to the outcome studies, and that was in JMPT in 2008, Nick Bogduck wrote an editorial that said basically if chiropractic wants to be considered a competent and a true profession, then it needs to answer 3 patient-centered research questions. One is, what proportion of patients improve with chiropractic treatment? In what ways do patients improve? And finally, for how long do patients remain improved? And because we had to get research up and going from nothing, we decided these were the 3 statements we needed to take on board. These were our 3 questions, and so that's how the outcome studies were formulated.
Right, and so we started creating, which turned out to be a really large database of outcomes for various regions of the body, particularly the spine. But the idea for the comparative effectiveness study came to me one day when I was reading 2 different articles in the New England Journal of Medicine. And they were saying comparative effectiveness studies were probably better than RCTs in many ways because they do not have such strict inclusion-exclusion criteria and therefore better represent patients seen in regular clinical practices. And these 2 papers further mentioned that many institutions already have outcomes databases that could and should be used for such studies. And they gave some instruction on how to do that. And a light bulb went on in my head, and I said, we can do that. And the reason we could do that is because I was in charge of starting the chiropractic outcomes database, and together with Kim, we devised the outcome measures. And I was also hired to work in the radiology department at the hospital to head up a new project that they had, and they had a big grant for it, to create outcomes database for the various imaging-guided injections that they routinely did every single day. And because of that, we used some of the same outcome measures since I was in charge of both projects. And so we also had some of the same time frame for data collection. And so I went to my colleagues in radiology, Professor Jörg Hodler and Professor Christian Fierman, who are well known in musculoskeletal radiology. I knew their names from their research papers for years and used their papers teaching my students in North America, and not ever dreaming I'd ever meet them, let alone work with them. And I presented the idea to them to do this comparative effectiveness, use the radiology database and the chiropractic database, and for this one was for lumbar disc herniation patients. And they were thrilled. They said, go ahead. So that's the background on how it got started. I'd like to say, even though, as you probably know from looking at the paper and the abstract, there was no significant difference between the two groups in terms of outcomes. I think that was a positive thing for chiropractic, because spinal manipulative therapy is somewhat controversial, at least I think in North America, for patients with disc herniations. And some colleges even teach their students that they shouldn't be manipulating these patients. Two of the co-authors on the study, Sarah van Leeman and Christoph Schmidt, together with the senior chiropractor in the practice, Dr. Bernard Onklin, they told me they were specifically taught not to do this, and yet they moved back to Switzerland and they were adjusting these patients all the time. And they said, and we get great results. And I said to them, yes, all chiropractors say that. I said, prove it. And so I told the youngest chiropractor at the time, Dr. Sarah van Leeman, who was then in the postgraduate program, I said, you write up the ethics proposal. If it gets accepted by the university, that will count as your postgraduate research requirement. And he did, and that's how it all started. So the cohort size was not as large as we would have liked, because we needed to age and sex match them. So we had 102 patients, so 51 in each group. And we only had 1 month outcome data comparing nerve root injections with SMT, because that was the time frame for radiology. That was the longest outcome time frame for this particular database. Certainly in chiropractic, we had much longer outcome time frames, but we could only do 1 month. And so 76.5% of the spinal manipulative therapy patients improved. And by improvement, we use the patient's global impression of change scale. So it's very easy for the patient to complete. It just asks them simply, since beginning treatment, how would you describe the change, if any, in your activity limitations, symptoms, emotions, and overall quality of life related to your painful condition? And there are 7 options for answers, ranging from much better to much worse. And they just have to circle one. And we only accepted much better and better as clinically relevant improvement. Slightly better, we did not consider that as improved. So 76.5% of the manipulation patients were improved, and 62.7% of the nerve root injection group was improved at 1 month. But that did not reach statistical significance, probably because of sample size, but still it's pretty good for both. And it was also less expensive to be treated with SMT compared to nerve root injections. So that's another positive thing for chiropractic.
One fact that stood out to me, the 53% of chronic patients in this cohort reported improvement, which is, by definition, chronic. It seems like things don't seem to work well. And so that's amazing to me.
Exactly. Very good point. And in the paper that we published just looking at outcomes from spinal manipulative therapy for lumbar disc herniation patients, we actually collected outcomes up to the 1 year time point. Now, this was not comparing it with nerve root blocks. It was just outcomes from SMT. And that was even more exciting, because at 3 months, 82% of chronic patients were improved, and at 1 year, 89.2% were improved. These are the chronics. I mean, I couldn't believe it when I was doing the statistics on those. Now, that's at one particular practice, and they have a special way of doing the treatment. It is high velocity, low amplitude SMT, and if anybody's interested, they can look that paper up on PubMed.
Very good, very good. Let's talk about the next paper, image-guided issues with cervical disc herniation, and it also compared spinal manipulative therapy to nerve root injections for cervical disc herniations. I wonder if you could tell us about that study.
Yes, exactly. It is the same protocol. It's a comparative effectiveness study, again, not a randomized clinical trial. And this one excited me even more, probably because the results were more positive for chiropractic, but also because particularly spinal manipulation for cervical disc herniation patients is, I think, in many corners of the profession controversial. But, at the same practice that we did the lumbar studies on, they certainly do it on regularly. So this time we had a similar cohort size, 104 patients in total. So half were receiving nerve root injections and half were receiving manipulation. And these were to the level of disc herniation. So they were age and sex matched again. We used the same outcome measures, the pain scale, the numerical rating scale for pain, and the patient global impression of change. But the thing that's different about this one is we now have 3-month outcome data instead of just 1-month outcome data. And that really showed in our actual results. So clinically relevant improvement was reported in 86.5% of the manipulation patients and 49% of the nerve root block patients. And that was highly statistically significant. P was 0.0001. However, more of the nerve root injection patients were in the subacute/chronic category. 77% of those patients were beyond the acute phase, compared to only 46% in the manipulation group. But when we looked specifically at patients in the subacute chronic category between the two treatments, it was still statistically significant. So only 37.5% of the nerve root injection patients were improved compared to 78.3% of the manipulation patients. So I think that says a lot and supports using SMT in patients with cervical disc herniation.
Yeah, absolutely. So curious to know then if these results have somehow changed the way that patients are dealt with in the orthopedic department at the university hospital and within the chiropractic facility as well.
Well, I don't know specifically the answer to that question since we retired in 2017, but in Switzerland in general, the chiropractors are not at all afraid of adjusting patients with disc herniations. And Kim can probably talk more about this, but the number of patients referred from the orthopedic department in the hospital to our teaching clinic certainly has done nothing but grow while we were there. In my experience working in 4 different countries in chiropractic education, as I alluded to before, students are often taught they should not adjust these patients. And I think these studies do not support that approach. I think their litigation fear is what stops them. Kim, did you want to add to that?
Yes. In Switzerland, chiropractors are considered primary spine care providers. They're part of the spine care team. So they do have access to all of the tools and all of the tests and other things that are necessary for making a proper diagnosis and making proper referrals. But in the hospital, we had probably about 50% referral of patients to our teaching clinic. And as was mentioned, these were very difficult patients. They had comorbidities and they had psychosocial aspects as well as their pain and disability problems. And these patients were treated by 6th year under assistance. So these were not chiropractors. These were to-be chiropractors, of course, under supervision. And still, remarkable results occurred. And another interesting point is sometimes we were criticized for just trying to medicalize our students and medicalize chiropractic. But the fact is that patients that came to us were not referred for more medical care or more prescriptions or more injections or whatever. They were referred for chiropractic treatment, and that's what they got. So we weren't medicalizing them at all. In fact, our colleagues in the hospital, they kept expanding the boundaries of the types of patients they used to send to us because our under assistants would get great results, and so they'd send something a little bit more difficult, a little bit more exotic, instead of restricting what we treated, they actually expanded it. Plus, we had some of the chiefs of different departments come in as patients themselves, and they experienced miraculous results. And they said, "You guys are magic. What is it?" So this was, being within this setting, we can really show what chiropractic can do, and that was an amazing experience for us.
Yeah, that's phenomenal, and I think it gets back to what Dr. Peterson was saying a few minutes back, that the young doctor who mentioned they got great results with these patients, it's a testament to that, and it's something that I've encouraged all chiropractors that I get involved with to share the results, to publish data, and so we need a lot more of this. So thanks for doing this. I'd like to talk next about another study which involves neck pain with and without dizziness undergoing chiropractic treatment. It was a prospective cohort study with 6-month follow-up. I wonder if you could share with us the information that you have about that study.
Okay. I had been interested in cervicogenic dizziness or dizziness of suspected cervical origin and whiplash injuries for quite a while. And back at this time, biomanipulative treatment for these types of conditions was a little bit controversial, but also the term itself, cervicogenic dizziness, was controversial. Now it's not quite as controversial, but there still is pockets of resistance here and there. And we understand that cervicogenic dizziness, it can arise from mechanical, degenerative, inflammatory, or traumatic problems that affect various structures of the neck. And with this dysfunctional mechanoreceptors in the joints, deep cervical tissues, and neck muscles, it's thought that this dizziness affects the cervical somatosensory system, and there's a mismatch of this sensory information from proprioceptors, vestibular, and ocular sensory input. So that's what is thought to create the dizziness. So our study the aims were to compare neck pain versus neck pain with dizziness and no trauma. Although we did have some trauma patients, we excluded ones that had whiplash, any type of whiplash trauma. But a few ones we did get in that had, say, falls or whatever. We also wanted to compare males versus female patient outcomes because it's been reported that females suffer a lot more from neck pain as well as cervicogenic dizziness. There's a few studies out that say that they suffer more than males. Now, the interesting thing is the study, it was all chronic patients. So these patients were chronic, and also they could not have had any type of treatment, manual therapy, or chiropractic therapy in the last 3 months. So it was a prospective cohort study, and it had a 6-month follow-up. Now, these patients were all recruited from chiropractic practices. So they weren't from our teaching clinic. They are actually from practices throughout Switzerland. And we had 81 chiropractors that participated in this. And the outcome measures we had to measure pain, we used the numerical rating scale. We also had current arm pain. We decided to look at that because that was an interesting thing that started to come up with some of our observations. And then we looked at disability in terms of activities of daily living, social activities, anxiety, depression, work and fear avoidance, pain locus of control. And then these were all measured with the Bournemouth questionnaire, and then also the total score for the questionnaire. And we looked at improvement using the PGIC, which was used in the other studies that Cindy mentioned. And this allowed us to divide patients into those that improved and those that didn't. So overall, for whatever variables patient feel is important, that's what the PGIC is. It doesn't matter whatever the patient feels is a problem for them with their pain problem, they had to report using the PGIC whether they felt they improved or not. So we had 405 patients from 81 chiropractors. 75% of the patients with dizziness were female. That was 177. And 58% of the patients were female where they had neck pain but without dizziness. So that was 228 patients, neck pain without dizziness. The neck pain patients with dizziness, they showed significantly higher baseline scores for current pain, arm pain if it was present, the disability, anxiety, depression, work and fear avoidance, pain locus of control. And for improvement, we found that after 1 month, we looked at their outcomes of 1 month, 3 months, and 6 months. After 1 month, we found that those with dizziness, neck pain and dizziness, 72% reported being improved. And without dizziness, so just neck pain, 73% reported being improved. And if you look at from 1 month, 3 months, 6 months, with dizziness, it was a constant improvement. So really the big, huge improvement occurred at 3 months with 81% reporting being improved, and at 6 months, 80%. So both those with dizziness and neck pain as well as those with only neck pain, they both significantly improved. So what did we learn? We learned that neck pain patients with dizziness reported higher pain and disability at baseline. We also learned that females are more likely to report neck pain with dizziness, and that both groups responded well to treatment. But interestingly, it's of those that did not improve, the small number of those that did not improve, and it was in arm pain, depression, work and fear avoidance. So it's very important to keep an eye on these factors, and that means it's important to be measuring these factors, and I would highly recommend using the Bournemouth questionnaire. 7 questions, biopsychosocial questions, very important. And particularly depression in females, to keep an eye on that. So neck pain with dizziness, arm pain, and being female are also not risk factors for poor treatment response. So that's what we learned from the study. And I think that's all good news, that it doesn't matter if you have this type of dizziness along with your neck pain, or that you're female, you're just as likely as others to improve with chiropractic care.
Yeah, great summary. And, one thing, it kind of brings me back to the previous 2 papers with disc herniations, that I think there's a thought somewhere, I don't know if it's within the schools at one point in time or just chiropractors in practice, but I get the sense, and I may be wrong about this, but I get the sense that some people think dizziness is a contraindication to chiropractic care, when in fact, clinical practice and your study in particular would indicate the opposite, that it seems to be an indication.
Yes, I think it is an indication, and I was lucky enough to work to establish a collaboration with a specialist in vestibular disorders, a neurologist at the University Hospital, and he asked me to come work with him and to treat patients together. And he expanded even that. He says, of course, cervicogenic dizziness, manipulation, that's what should be used. But he even started saying, patients that have vestibular dizziness, that unless they get treated for their neck problems, they won't completely improve. Now, this was a huge step forward. And I thought, wow, that's wonderful. And there was a few neurologists working with him, and they said, yes, they need to be treated by chiropractors with manual therapy or SMT, because that's what will really help them completely improve.
And I think that beautifully shows how important it is to be within the system instead of out of the system, because you have the opportunity to work together with other specialists and that you can see what each other does. And it's all about the patient. It's all about what's best for the patient, not what's best for the individual practitioner or the individual specialty. We all should be looking toward working to help the patient. That's just my opinion.
Absolutely, and such a great point. I mean, how could they possibly know what we do if they don't see it or they don't have any exposure?
Exactly.
So,
Yeah.
amazing. Okay, so let's talk about one last paper here, and this is an observational study on trajectories and outcomes of chronic low back pain. And it somehow gets back to the first paper we talked about, which included improvement in the chronic low back pain patients. But this was a different study, a more recent study. So could you tell us about that study?
Okay, so this was a similar type of study, but the difference, one of the main differences, was the patients were referred to our under assistants. So they were treated by our under assistants. They weren't treated by chiropractors in general practice. In Switzerland, of course, we had that lovely opportunity. We were part of the Joint University Spine Center. So there's multiple disciplines: orthopedics, neurosurgery, neurology, chiropractic medicine, rheumatology, anesthesiology, and radiology. So we're all closely working together, and the focus is on improving patient care. And that's why we were accepted as part of the care team, is because we focused on the patient. They saw that. That's what they're focused on. We're not focused on proving that chiropractic works. We're focusing on how to improve patient care. So that's the background to that. So we had referrals. So we had 67 participants, 31 were males, and 46 had suffered low back pain for greater than 1 year. So most of them were very chronic, and the rest were greater than 3 months. So all of them were chronic and quite difficult, comorbidities and other biopsychosocial problems along with it. So at baseline, their pain intensity, which we measured with the numerical rating scale, was 5.43. And it was reduced at, but not before 6 months, but eventually it was reduced to 3.15. So the pain decreased significantly. We found with the Bournemouth questionnaire on all of the biopsychosocial variables that at start it was rated as 39.8, and that would have been out of a total score of 70. But still, that's a very high rating. Normally, you would see back pain patients, even chronic patients, probably down in the 20s. And at 12 months, there was a significant decrease to 29 for the total Bournemouth questionnaire score. But there was also found after 1 month a significant decrease in the Bournemouth questionnaire scores. So for improvement, we used the patient's global impression of change, and we found after 1 week, 23% reported being improved. At 1 month, there was 47% that stated they were improved, and then it remained more or less stable. So we had 56% at 3 and 6 months and 44% at 12 months. Now, interestingly, the median number of treatments given was 8, but there were 3 patients that had more than 20. And what we found, a significant thing which we found, was pain was not really the most important thing for most patients, but it was biopsychosocial aspects that were more important to them, and disability. So pain should be considered something that we do measure, but biopsychosocial is more important. And that's what what we found in these patients reported. So it's important, again, to assess. We need to assess biopsychosocial factors in practice, and that means using instruments such as the Bournemouth questionnaire. It's only 7 questions, easy, to give to patients and for them to respond and to score it and use it for managing our patients. So chiropractic treatment, it's a valuable conservative treatment. It shows how we can be involved as a team player within the spine team, even for very difficult chronic low back pain patients. And this further cements us as spine care experts within the multidisciplinary team within the university hospital setting.
Fantastic. Yeah, and it makes me think about the newest paper by Sidney Rubenstein, the systematic review of SMT and chronic low back pain, and this just further provides more evidence for that, and fantastic. And I think the 3 points that you made from Dr. Bogduk the reason why you started these, I think you've accomplished that very well, and wow, what a great series of papers, and I know you've published so many more, and we've just talked about 4 of them, but thanks for going through that. It's tremendous. I would like to ask both of you, before we finish today, one important thing that I feel is part of the podcast is I like to try to motivate and assist practitioners and students alike to pursue research careers in chiropractic science. So I'll ask both of you, could you offer any advice to these aspiring chiropractors or students who may wish to become scientists in the future?
Okay, I'll start. Well, I would say a few things. I think they should routinely collect outcomes on all their patients, because not only is it good feedback for the patient in the practice, but you never know when you're going to be able to use it in the future for some kind of research study. And these can be as simple as the NRS pain scale and the patient's global impression of change. But as Kim said, the Bournemouth questionnaire is also excellent and short and easy to do. And these can be done online by the patient. I also would suggest to some of them to do a PhD and explore all options. And by that, I mean, do not be afraid to move away from your home country. That was the smartest thing I ever did, I think. Well, there were many smart and stupid things I did, but one of the smartest was to move to England when I was a young chiropractor, and I'd never been there before and knew nobody. And that's really started my research career, and in other ways, it really opened your eyes, too. So I was so happy to find out recently that one of my former students from Canada, who went on to get his PhD, is now going to be part of the research team at Balgrist Hospital in Zurich. That's really exciting when a former student is doing something like that. So don't be afraid to move. Don't be afraid to get postgraduate credentials in research. And please collect outcome measures on your patients. That's my input.
Yes, I totally agree. And for myself, I had to move from Canada to England to be able to do a PhD because at that time, part-time PhD programs were possible, so I could still work and do a PhD. Of course, it takes you longer, but it was not possible at that time in Canada. So I had to move to England, which was great, great move. For many different personal and as well as professional reasons. So definitely a PhD. I think now there are a number of very good chiropractic researchers that are established within universities. So I would seek them out. I would discuss things with them. I would maybe come up with research questions or a line of research that you wanted to be involved in, possibly even see if there's funding or a possibility of working with them. And I think looking for questions that are really important for patient care referring to chiropractic treatment. So focus on the patient. What are the questions we need answers to? And I think that really is a good way forward. I'm sure there are others, but I think those are probably the main ones at this point.
Great advice, and thanks to both of you for coming on the podcast. Really appreciate the insight. I've wanted to know about your research for some time, and I know chiropractors around the world will get a lot out of this interview. So thanks for spending the time and talking with me today. Again, really appreciate it, and appreciate all that you've done over the years within chiropractic research.
Thanks for inviting us.
Yeah, thank you very much. We really appreciated doing this and being able to share these experiences that we had with you and the chiropractors. And we wish all of you the best and continue to do your excellent work in practice. And Dr. Smith, continue to do your excellent work also. Thank you very much.
Thank you.
Thanks for listening to this episode with Doctors Cindy Peterson and Kim Humphreys. Please share these episodes with your colleagues and your chiropractic associations, as well as on social media, so we can get chiropractic science out to the masses. Sharing the research with the public will promote chiropractic to those who need it, as well as those who can affect public policy. Stay tuned. I'll be back soon with more great chiropractic science episodes.